Hello friends, we are going to discuss the reproductive system in this lecture. So we'll begin with the anatomy and then the normal functioning and then move on to the disorders. Okay, first we'll do the male and then the female. So this is the anatomy of the normal male reproductive system. We can begin from here. This is the, as you can see, this is the penis, the foreskin. There is the urethral opening in the penis which is going all the way up with the connected with the bladder. In between this is the prostate. There is the seminal vesicles and the ejaculatory duct which is coming out from the vesicles, and from that the secretions get together into the urethral opening. So the same opening which is used for the urination is also used for the ejaculation. Okay. uh, there is also testis in which the sperms are getting formed. They are formed in from spermatogonia. The process of spermatogenesis occurs in the testis, and they are stored in the epididymis. Then they are carried through the vas deferens, from where they are coming and getting mixed with the seminal vesicle fluid, which provides nutrients, the motility to the sperms, and then they are going into the secretion here. Okay, this bulbourethral gland is also providing easy movement of the sperms. All the secretions are basically added to improve the motility of the sperms. Okay, so now we are going to look at what are the congenital abnormalities of the penis. There are two common congenital abnormalities that are seen. Sometimes the opening is below, as you can look here, under surface, that is hypospadias. Sometimes it is associated above on the dorsal surface, that is called epispadias. Okay, so they are the most common seen ones. And epispadias is also said to be associated with extrophy of the bladder. What do I mean by that? That if the in child has epispadias, then the chances of the child having an open or exposed bladder is also there. I mean, that's high. Okay, so those are the two congenital abnormalities of the penis. They are generally surgically treated. Okay, what is a normal physiology? How does the testis develop? So normally when the testis develops, it's somewhere over here, okay, above, in the fetus position, like around about 7 weeks it starts developing. Okay, then it starts descending. You see over here, it starts descending. By 12th week it starts coming down, and it starts descending into the groin, and it should by about it should come into the scrotum at about 4 to 6 weeks before birth. At birth the testis should be present in the scrotum. Okay, that is how the normal descent of testis happens. Now sometimes the testis do not descend normally. The passage can be changed. That abnormal descent is called as cryptorchidism. Now there can be a true cryptorchidism where truly the testis has remained, it was following the path, but it is stopped in its path somewhere over here in its normal path. If it is still in the abdominal. If it is in the inguinal, it's the inguinal position. If it's in the above the scrotum, it's the suprascrotal position. Okay, but that's a true cryptorchidism. It is called ectopic when it is outside its route of descent, the normal route. So that is, it could be prepenile, just above the penis. It could be in the femoral, in the lag region. That is an ectopic cryptorchidism. Okay, it is very necessary to fix the testis, this cryptorchidism, because the chances of this testis at abnormal places developing cancer is very high. Okay, so we need to fix this cryptorchidism. Also, if you do not bring them into the scrotum, there is a chance that the person may develop infertility. Okay, what are the other complications, or the other sorry, not complications, but what are the other conditions? There can be an accumulation of fluid in the scrotum, that is called as hydrocele. There can be cystic mass on the epididymis, that is called as spermatocele. there is blood supply to the testes, right? So there can be a dilatation of the venous plexus, and that is called as varicocele. Okay, there can also be a torsion of the testis. This is a condition, a acute complicated condition seen in young individuals, in young males. The testis gets it's there is a torsion, it turns around on the vessel. So as it turns around, the blood supply to the testis is blocked. Because of that, suddenly there will be a blockage of the blood supply. Person will feel a lot of pain, and so it has to be acutely treated, because if the blood supply is not retained, the chances of individual developing infertility or decreased sperm count is high. Okay, so that is torsion of testis. The in hydrocele, generally the fluid is gathering between the layers of tunica vaginalis, and the test we do is use a torch and pass light through it, called as trans illumination. if, if the light can pass through it and glow up, like illuminate, then there is fluid, there is no malignancy, or there is no solid mass in it, so it confirms the diagnosis of hydrocele. Sometimes there can be loops of bowel which are coming down along with the testis. In a young baby child, the loops of bowel might also be coming down. That can lead to a hernia like condition. Okay, the cyst containing fluid and sperm in between the testis and epidermis is called as spermatocele. And we discussed the varicocele, and we also discussed torsion of testis. Okay, that's the ischemia of the testis. Now, what are the infections and the inflammations? Infection, if prostate is another important organ which helps in providing the nutrients to the sperm. Any infection to the prostate leads to a condition called as prostatitis. Okay, it can be acute bacterial or chronic bacterial, or not non-bacterial. It can be asymptomatic, it can be inflammatory, and it can lead to, it's prostated over here, right? So it can lead to an ascending infection which can go and affect the bladder also. Okay, so it's important to treat the prostate infection. Okay, the next we are talking about is candida balanitis. There is an infection, candida infection. So it manifests as a redness or blotchy rash. There is a thick lumpy discharge, because and it is generally seen in immunocompromised individuals, and the foreskin is infected over here. Okay, uh, generally the babies undergo circumcision so that they do not develop these kind of complications. Okay, they are only developed when the circumcision is not done. Okay, it is generally transmitted by sexual activity, and the treatment is giving an antifungal. Okay, now we are going to come to the tumors of the male reproductive system. The first one is the BPH, second one is the cancer of the prostate, and the third one is the cancer of the testis. So what is BPH? BPH is benign prostatic hyperplasia. It's a benign tumor, but it can cause obstructive symptoms. So you see over here, this is a normal prostate, normal bladder. This is the hypertrophic prostate. You see the size has increased, so urine, the passage has decreased. Because of that, the backflow of urine has increased. Because the backflow has increased, the bladder wall is also getting thickened. Okay, so the complications can increase in the individual. So although it's a benign tumor, it is almost always operated. Okay, it is generally seen in individuals who are greater than 65 years old, because there is an hormonal imbalance. Till that age, estrogen is less and testosterone is more, but with aging, the balance between estrogen and testosterone gets disturbed. There is an hyperplasia of the prostate which blocks the urethra, causing the urinary obstruction, which leads to an incomplete emptying of the bladder, which can lead to stasis of urine in the bladder, which can lead to infections. Okay, the continuous bladder obstructed gets filled, there can be a back flush into the ureter, which can cause infection from the ureter to the kidney also. And it can, the back flush can also cause hydronephrosis, or dilatation of the kidney due to the fluid, due to the urine not coming out. Okay, the signs and symptoms of BPH is generally hesitancy, dribbling, decreased force of the urinary stream, increased frequency, nocturia, recurrent urinary tract infection. Most commonly, the individual will come with the complaint that I want to go to pee, but I have difficulty in starting it, and it comes out very less. And just when I have returned from the washroom, I again feel like peeing. Okay, so a constant need to urinate, and whenever they go to urinate, the volume does not come out, it does not get emptied completely, right? That is how the BPH individuals present. Treatment is surgery. If for the time being they want to manage it by medical, then there are some drugs called alpha blockers which can relax the smooth muscles, and they can help with the urination. Okay, till the time the surgery is being scheduled, but the definitive treatment is always surgery. Okay, next we are going to discuss is the cancer of prostate. So it is the second leading cause of cancer death in the men. It is type is because prostate gland is a gland, so the type is of course adenocarcinoma. Hormone dependent growth of it is depending on the hormone, so it is a hormone dependent growth tumor. It is depending on the cell. The more badly it is differentiated, the more the tumor is going to be aggressive, and it can spread very fast, at a very faster rate. Okay, better screening will help us identify the pathology early. There can be some studies have found that there are genetic mutations like HPC1 which are associated with the cancer of prostate. Signs and symptoms can be a nodule which is generally palpated when you do a digital rectal examination. Also, the patient can, the individual can complain of hesitancy, or a decreased stream, or a urinary frequency, or a bladder infection. Now, mind you, to be honest, it is difficult to differentiate cancer prostate and BPH, because both of them feel like a nodule when you are palpating them by a digital rectal examination. So what do? They can do a PSA, prostate specific antigen test. If it is elevated and the rectal examination also you feel like a nodule, a solid hard nodule, it's going to be an adenocarcinoma. But if the PSA levels are not elevated, and when you have done the digital examination, the nodule, there is a nodule but it's not so solid, so hard, then there is a chance it is going to be BPH. Okay, so also you can take a biopsy. If you are very doubtful, you might need to take a biopsy, and which is reported with a Gleason score. So Gleason score is the one where how badly the cells are looking, how abnormal the cells are looking, and what are the percentage of those abnormal cells. So based on that the score is calculated, and based on the score it is decided what the treatment is going to be. Surgery, and it's generally surgery and radiation, and to remove any effects, even orchidectomy is done. So the hormonal stimulus, the testis hormone that is released by the testis, is gone. Okay, but when you remove the testis, the individual may develop impotency, right? So this decision is taken based on the age of the individual and their desires. Okay, next we are going to discuss the cancer of the testis. The cancer of testis, most of the cases are going to be malignant. It is the most common solid tumor which is seen in young children or older males. As I said, most commonly seen associated with cryptorchidism. The main types, the common types are seminoma, where the tumor is on the one type of the cells. There can also be a teratoma, where the tumor is a mixture of all the germ cells. So when you are talking about teratoma, if you cut open a teratoma tumor, you will see a a tooth inside a testis, tuft of hair inside a testis. You can see mucus in the testis, all the different kind of things in the testis. That's a teratoma. Okay, teratoma is also seen in ovaries. Okay, it's not just testis. Tests that are done are serum markers, AFP, alpha fetoprotein, and HCG, human coronary gonadotropin. Okay, these are the two which are elevated, can help us tell that there is a tumor, a cancer of the testis. Most common causes is either hereditary, which is associated with chromosome 12. There can be infection, there can be any trauma or cryptorchidism. Signs and symptoms are a hard, painless unilateral mass, dull aching pain in the lower abdomen. There can be also gynecomastia, development of breast in males, which is because of the hormonal imbalance. Treatment is generally surgery, where you remove the testes, and radiation and chemo to make sure that all the malignant cells are dead. Infertility will definitely develop. So, sperm banking can be thought about. Okay, before undergoing the procedure, it is necessary to think about sperm banking. So that was all about the male reproductive system. Let's discuss the female reproductive system. So this is how the normal female reproductive system looks like. You can see over here, this is the uterus, which is a sac-like structure, which is there is in the continuation there is a cervix, and in the continuation with that there is a vagina, which is the contact with the outside. uh, the uterus has this is a fallopian tubes. The ovaries release the eggs which pass through the fimbriated end into the fallopian tube. The fertilization generally happens over here in the fallopian tube, and then the embryo will come and implant itself here somewhere in the endometrium. Okay, that is all about the female reproductive system. The vulva, the external reproductive system, has mons pubis, labia, clitoris, and vaginal orifice. What is mons pubis? It's adipose tissue and the hair which is covering the symphysis pubis. The labia majora is the outer fold. The labia minora is the inner fold, and it is long and thin fold of the skin. Clitoris is the projection of the erectile tissue which is anterior to the urethra, and it is very sensitive to touch. Vagina is a muscular canal from the vulva to the cervix. It is lined by stratified squamous epithelium, and in mucosal lining it is continuous with the columnar epithelium. It can lead to a sanding infection from the vagina to the cervix, which can affect the uterus also. The pH of the vagina is generally acidic, so that in the reproductive period, okay, so that the infection cannot happen quick, very like easily. Leukorrhea is an abnormal vaginal, it's a normal vaginal discharge, but it is whitish in color, so it kind of sounds scary when the girls have it, but it's a normal vaginal secretion which is generally happening during the times of stress. The squamous lining from the vagina to the cervix. So in the cervix, when it is going into the endocervix, that is ecto to endocervix, that's the most common place where the malignancy is going to develop. Okay, uterus is like a sac-like organ. It is the normal position of the uterus is generally anteverted, and it rests on the bladder. The layers of the uterus are outer peritoneum, middle muscular, and an inner endometrial layer. The endometrium layer has two layers, which is one of them is the basal layer, and then there is a functional hormonal layer. Why? Because the functional hormonal layer always keeps on breaking down depending on the concentration of hormones, and then there is a basal layer which is responsible for the regeneration of that functional hormonal layer, right? Ovaries is to secrete the estrogen and progesterone, and they supply the egg or the gamete in the each cycle. Lactation is done by the female breast. The mammary glands develop under the influence of the estrogen. That is all about the female reproductive system. The normal physiological menstrual cycle is like this. So there is two phases, so follicular and the luteal phase. There is a low estrogen in the beginning. Okay, there is a FSH secretion. The FSH causes the follicle to grow. You see, the follicle is growing in size, and the follicle grows under the influence of the estrogen. Then suddenly the LH will rise, the peak of LH, which will come and give a smack on the ovary. Because of that, the ovulation occurs. See, the egg is coming out. The ovulation will go and stay in the endometrium for around 4 to 5 days. After that, the progesterone will come into action. The progesterone will cause the egg to disintegrate, and the the place where the ovary had developed the follicle, it will get converted into corpus luteum, and it will get converted into corpus albicans, and solid, it's like white area in the ovary. Okay, but in the endometrium what will happen is, and then the menses happens. Okay, now that is what happens in the ovary. And what happens in the endometrium is, in the follicular phase, in it's called a proliferative phase in the uterus, in the endometrium. So the under the influence of the hormone estrogen, the functional layer of the endometrium will increase in size, and it will become very thick. Then the ovulation happens, so the layer is ready for the implantation to occur. It is highly vascular, and then the secretory phase begins, by which the egg is also dying, and the endometrium also starts dying under the influence of the progesterone, and the lining becomes very vascular and edematous, and it starts getting broken down. And as it starts getting broken down, menses happens. Okay, that's all about the menstrual cycle. The same menstrual cycle in ovary is called follicular and luteal phase, and in the endometrium it's called the proliferative and the secretory phase. Okay, and both of them occur under the influence of estrogen and progesterone. Now we are coming to the basic. What are the structural abnormalities? Remember, when we were discussing the normal anatomy, uterus is anteverted. Okay, that is normal, like this, anteverted and resting on the bladder. Sometimes the bladder can be compressing the uterus, and because of that it can be sorry this is the uterus, this is the bladder. So sometimes the uterus can be compressing on the bladder, and because of that it will be coming out. So that is called as cystoscopy. Okay, because it's both the structures are pressed against each other, and they may be pressing on the place, and so bladder is, uterus is a bit high up, bladder is bit lower, right? You can see over here it is a bit lower, uterus is higher up. So as they both press on each other, bladder is, the chances of bladder coming out is more. So the bladder comes out, and it leads to a condition called as cystoscopy. But when there has been multiple pregnancies, the uterus position changes. Okay, and it is not so well situated like it was normally. So the uterus starts coming down, and so that is called as prolapse. You see over here it has totally come down, so that is uterine prolapse. Now there are degrees of uterine prolapse. Okay, first degree, second degree, third degree, depending on how much portion of the uterus is coming out. Okay, that's the uterine prolapse. Now we're discussing about the menstrual abnormalities. So what are the abnormalities which can be seen in the menstrual cycle? There is amenorrhea, absence of menstruation. Now there are two types of amenorrhea, primary and secondary. Primary amenorrhea is the term used when the individual has never had menses. Okay, the menarche, the beginning of menstruation, has not happened. It is generally seen in the conditions like genetically internal syndrome, or there is any congenital defect which is affecting the hypothalamus or the CNS of the pituitary. There can be a congenital absence of the uterus, or there can be a congenital uterine hyperplasia. Now, secondary causes which can lead to menstrual abnormalities can be they are used when there is a cessation of menstruation in an individual with previous cycle. So previously the individual had normal menstrual cycles, right? But now due to some reason the menstruation is not happening. Of course, the first thing you do is rule out pregnancy, okay? But if it is not pregnancy, you can look at the HPA, the hypothalamic pituitary axis. It might have been altered. The hypothalamus might have been suppressed by the tumor. There might be some stress disorder, weight loss, or any eating disorders. Also, anemia or chemotherapy may also cause secondary amenorrhea. Okay, so all these causes may need to be looked into. Now, what is a premenstrual syndrome? Premenstrual syndrome are the one which is associated with menstruation. The one of them is dysmenorrhea, where it is a very painful menstruation. The other types are abnormal menstrual bleeding, like if there is menorrhagia, where there is an increased amount and duration of flow. Metrorrhagia, where there is bleeding in between the cycles. Polymenorrhea, where there are short cycles of less than 3 weeks. So you just had menstruation and again within a week again you have menstruation. That's polymenorrhea. Oligomenorrhea, when the cycles are greater than 6 weeks. Okay, these are all the abnormal menstrual bleeding. The menstrual bleeding should go on in a cycle of 28 days normally. Okay, like normally within 28 to 35 days the menstrual cycle should be getting over. But if it is longer than that, that means something is wrong. That's oligomenorrhea. Okay, and if it is shorter than that, then that is polymenorrhea. What is PMS, premenstrual syndrome? It is a condition which begins a week or so before the onset of menses and it ends with the onset of menses. What are the signs and symptoms? That will be breast tenderness, bloating, irritability, sleep disturbances, depression, headache, and fatigue. The treatment generally is hormonal therapy, diuretics, and antidepressants if the symptoms are very severe. Okay, but generally those who develop premenstrual syndrome, they find out a way to live with it, because this is something which is going to happen every month, right? So over a period of time you develop your coping mechanism with this. If you cannot, you have tried everything, all the exercise regimens, all the eating stuff and everything, and still you cannot control, then visit a physician and they, if needed, they might give you prescription drugs, whichever is indicated. Okay, endometriosis. Now that is a pathology which you can see. Endometrium is an inner lining of the uterus. So endometrium is supposed to stay inside, but when it is not over here and you find it over here, or you find it in the ovary, or you find it outside here on the uterus, or you even find it here, sometimes you also find it in the broad ligament. So these are all the abnormal places of endometrial glands. They are functional endometrial glands. Okay, so as per the cycle they will become thicker and then they will also cause bleeding. So imagine there is bleeding happening over here in the ovary, there is bleeding happening over here in the broad ligament. So it will irritate the surrounding structures, it will cause pain, it will cause different kinds of signs and symptoms. So that is endometriosis. When the endometrial tissue is outside the uterus, on the ovaries, ligaments, or colon also in some cases, that is called as ectopic endometrium. There is cyclic hormone variation, grows during the proliferation and secretory, and degenerates and sheds during the later phases. Blood will cause irritation and it will lead to a formation of fibrotic nodules. There are big thickened nodules which will develop here, okay, because of the bleeding. The diagnosis can be done with laparoscopy, and if needed we can find out why the pain is there, and if there are any adhesions or any infertility can develop because of that. Because if there is endometriosis happening in the ovary, the follicle is not going to form, that can lead to infertility, remember. So that's why it has to be diagnosed and it has to be managed. When it is happening in the ovary, the ovary becomes hemorrhagic, brown color, so it looks like a cyst which is filled up of chocolate, so it's called a chocolate cyst. Okay, there's other term used for endometriosis in ovary. It presents with generally endometriosis presents with excessive pain during menstruation, so we need to rule it out, right? We need to rule it out with a PMS, a premenstrual syndrome. And that's why when the individual comes with pain or a PMS complaints, you try to investigate before labeling it as PMS. Okay. Treatment is generally in endometriosis a hormonal suppression, because you need to suppress this ectopic endometrial tissue, right? Now, what are the infections and the inflammation? Then we are going to talk about candidiasis, pelvic inflammatory disease, staphylococcal infection, which is a toxic shock syndrome, which is associated with the use of tampon. That I have mentioned over here only. I'm not going into detail. So it has been found out that because of the excessive use of tampon, which is an abnormal, which is a foreign thing that is lying in a inside the cavity, right? So sometimes it was the case studies were done where the individual forgot to remove the tampon from the body, and so it got infected by the staphylococcus infection, which led to a toxic shock syndrome, which is very bad because a generalized septic condition develops in the individual. Hence it is very necessary for those who are using tampons to be careful when they put it in and when they discard it. Okay, we are discussing candidiasis here. It's a yeast infection which is caused by Candida albicans. It is not transmitted sexually. It is an opportunistic superficial infection of the mucous membrane. The cause can be anything that has led to immunity suppression, either because of the antibiotic usage or because of the diabetes or because of any immune deficient condition can cause candidiasis. Okay, signs and symptoms are red and swollen pleuritic mucous membrane and thick curd like discharge. There can also be dysuria and dyspareunia, problem in urination and problem during the sexual activity. Treatment is antifungal, which is nystatin. Okay, next important concept that we are discussing is a PID. So PID is a pelvic inflammatory disease, and it is kind of like a systemic, not systemic, but a total infection of the reproductive organ. Okay, so it can be because an STD causing bacteria enter vagina with the semen. Bacteria will pass through the cervix and enter the uterus. It can enter the fallopian tubes and the ovaries, and that can become infected. It can leave the fallopian tube and spread to other parts of the body as well. So that is PID. Okay, what happens, look, in PID there is this normal female, normal ovary and the fallopian tube, and when there is pelvic inflammatory disease, there is pus everywhere. You see, also in the fallopian tube, in the ovary and everywhere. That is why PID is it is necessary to treat PID. It can be an acute or a chronic. It is basically a bacterial infection, but it can spread to many different parts of the body. Okay, so it needs to be treated. It can be an acute or chronic. Complication short term is generally peritonitis and pelvic abscess. In the long term, it can cause infertility, and if it is still there, it can cause the implantation can happen in the fallopian tube. It can cause ectopic pregnancy. The ascending infection passes out through the fimbria, causing peritonitis, which leads to adhesions of the scar tissue. Causes is generally the most common organisms which cause pelvic inflammatory disease are gonorrhea, chlamydia, and can also be E. coli, um, bacteroids, etc. So they are all gram-positive bacilli and gram-positive streptococcus, and they are also seen post to the insertion of IUD, intrauterine device. The PID is most commonly seen also after miscarriage or an abortion. If there is incomplete removal of the products from the uterine cavity, it can lead to PID development. Okay, also if an IUD is inserted, if it is not changed at regular at the defined interval, or if it is anything is not taken care of, it can lead to PID formation. Generally the individual will present with a lower abdominal pain which is very dull. Okay, it's not a pinpointing pain, it's a very dull and a generalized kind of a lower abdominal pain. The treatment is very simple. You have to give antimicrobials, the antibiotics. Okay, So that was about the infections of the female reproductive organs. Now we are moving ahead to the tumors. So the tumors of the female reproductive system are benign or malignant. The benign tumors of the uterus are called as leiomyoma or fibroid. They are of the three types. If they are in the muscular, inside the muscles, they are called as intramural. If they are inside the mucosal lining, they are called the submucosal. And if they are towards the outside lining, they are called the subserous. Okay, they can be multiple, they are benign and they are well defined but unencapsulated because they are developing in by the muscles, right? They are hormone dependent. They may cause compression on the other organs because they increase in size. They interfere, if they are over here, they can interfere with the implantation of the fertilized ovum. And the treatment is generally, we can try and give hormonal therapy to reduce its size, or most commonly you can do a surgery like myomectomy to remove the fibroid. And if the patient does not desire child, like in the later ages, they can get the hysterectomy also done. Okay, the next tumors we are going to talk about is the polycystic ovarian syndrome, PCOS. It was very well discussed by the presentation in the class. It is the other name for PCOS is Steen-Leventhal syndrome. What happens is, you see over here, this is a normal ovary, these are the normal follicles developing. PCOS, you see over here all these purple cysts. So there are so many cysts developing in the ovary. Okay, and they are all the cysts are covered with the thick capsules. They can be hormonal abnormalities like elevated androgen, estrogen and LH levels and decreased FSH levels. The ovulation, because the cysts are covering up the whole ovary, the ovulation cannot occur. Okay, there is a dysfunction in the hypothalamic and the pituitary axis. The it is a cause which is leading to the development of PCOS. Okay, so it's like a complex, it's not like one thing led to the other led to the other. It's like a complex of all the things going wrong at the same time. The HPX is not maintaining, the hormonal levels are not maintaining, the weight is the individual is not maintaining the weight, and so everything is going haywire and everything is contributing to the development of PCOS. And generally the patients are recognized when they come with a complaint of infertility. Okay, the signs and symptoms of PCOS can be hirsutism, amenorrhea, and infertility. The individual can come with a complaint of a change in the voice or developing male features like increased hair on the face. They can also come with the complaint of amenorrhea, that they have done the UPT, they are not pregnant but they are not getting their periods properly. And also if there is a married couple, they are having problems with the fertility and the female comes for checkup, then there can be a cause of PCOS, can be a cause. Okay, what are the signs and symptoms? Hair loss, hirsutism, pelvic pain, overweight, acne, irregular periods, infertility, and high testosterone levels. Okay, there is I think there is only one drug like clomiphene citrate, which is an anti-estrogen which is used to stimulate ovulation if in those individuals who have come with the complaint of infertility. Okay, otherwise you can do a resection of the ovaries to remove a portion of the ovaries so that the hormones can be controlled. The most commonly prescribed drug is OC pills because they can reduce the testosterone effects and they can bring hormones, the female hormones in the body. And in those women who have gained weight, there is insulin resistance, so metformin can be given because that is said to improve the weight management and also improve the symptoms of PCOS. Okay, these are the other steps, like there can be lifestyle adjustments where you can have a nutritious diet, a regular exercise and good habits. And there some people also opt for alternative therapy like hormone related supplements, herbal supplements, or you can also go for hormone treatments or anti-androgen or anti-diabetic drugs. The anti-diabetic is the metformin I just talked about. Okay, now we are coming to a benign disease of the breast. Because breast is included with the female reproductive organs, we are going to discuss some portions of the breast also. So fibrocystic breast disease is a benign tumor like condition of the breast. There will be nodules or masses which develop in the breast associated with the menstrual cycle. Cyst develops when there is a secretory phase which enlarges over time and causes more degenerative changes. Okay, so cyst develops in the breast during the secretory phase, and it will secretory phase of the endometrium, remember, of the menstrual cycle, and at that time in the breast a cyst may develop, and over time it does not degenerate. Okay, so over time it will again cause more degenerative changes. So there can be non-proliferative lesions which are called microcyst and fibroadenoma, which is like the benign tissue of the fibrous of the breast, or the benign tumor of the glands of the breast. Proliferative lesions where there are no atypical cells but epithelial hyperplasia is seen in the ducts. So there are ducts in the breast, and they are lined by epithelium, so those epithelial lining will be hyperplastic, they will be increased. Okay, risk of cancer only increases in these cases if there is an associated family history of breast cancer. Okay, there there is a third category which has proliferative lesion with atypical cells, and they definitely require monitoring. The diagnosis is done by biopsy. The signs and symptoms is the breast become heavy and painful. Treatment is generally symptomatic. Also, you can have dietary changes like reduce the caffeine intake, fat intake, and drugs such as androgen and denisol. They can also help with the condition. This is the diagram which is showing this is the normal and this is the fibrocystic. You see, this is the normal, the ducts, collecting duct coming towards the nipple, but here cyst developing into the ducts, that is the fibrocystic disease.